Good evening, everyone, and thank you for joining us for Season 6, Episode 6 of Doc Talks with Dr. Forrest Tennant and friends. We have an exciting show ahead of us and some miracles, I hear, so I will just go ahead and let you take it from here. Thanks so much, Dr. Tennant. Thank you. It's all yours.
Thank you very much, Jamie. Yes, we've got a good show here this evening. Our old friend Donna Corley, who's been an advocate for many years, is going to be with us, along with my regular associates, Drs. Guess and Dr. Ibsen. And we're going to start with an educational message here to start with, as always. And I'm going to start with giving you the basis of a letter I received this past week. And it goes something like this. Dear Dr. Tennant, a few years ago, I had an implanted electrical stimulator for my adhesive arachnoiditis. It almost totally relieved my pain, and I've done beautifully with it. But all of a sudden, a few months ago, I went into some great break. I developed severe intractable pain. I couldn't walk. I was so weak. My bladder isn't working. My legs are weak. I'm falling apart. What's happened to me, and what do I do? Well, this is a good example of something that is I've talked about before, and I'm going to talk about again tonight because it is the crux of trying to treat adhesive arachnoiditis and some of the other intractable pain conditions. And that is the difference between symptomatic treatment and treatment for the disease. Another thing that's been happening, our foundation now has a service in which we'll review somebody's treatment plan, and they're also part of our research studies. And what I'm getting at is that, believe it or not, after all of this time and these many years that we've harped on this, we have people who are doing nothing about the treatment of inflammation, which is the heart and the cause of adhesive arachnoiditis, CRPS, most neuropathies, and certainly central pain. And in other words, they're doing absolutely zero for the inflammation, but they're so focused on getting pain relief that they have ignored the basis of their disease. Now let's go back for just a moment to what an electrical stimulator is and how did this man get into such difficulty? Well, he got into difficulty because first off, his doctors deceived him, okay? His doctor said, the stimulator is going to relieve your pain. This is your treatment. And so they put in the stimulator. His pain was relieved. And he and his family are delighted. They've got their life back. They're functioning and they're going ahead. What they didn't realize is that inflammation inside the spinal canal is a very indolent, slow process in most cases. It's not acute, it's not sudden, but it slowly grows. In other words, adhesive arachnoiditis is fundamentally a disease of spinal canal inflammation. In fact, in 1873, believe it or not, the medical dictionaries defined arachnoiditis as a disease of inflammation of the arachnoid membrane. In other words, it's been known to be that inflammation was the root cause of the problem for over a century. Now, what's happened and where the deceit comes in is when people are told that your problem is primarily pain, and most people today are sent to pain clinics. And pain clinics, and let's face it, I'd like to have Dr. Guess and Dr. Ibsen make some comments about this later. As a group, pain clinics in the United States treat the symptom of pain. They do not treat disease. They didn't sign on for this. They don't advertise they do such. They never intended to. They treat the symptom of pain. They do not treat your disease. Interestingly enough, I've run into some anesthesiologists and some pain specialists who are starting to incorporate the treatment of the diseases in their clinics, but they're few and far between still at this time. So for all you folks that are going to a pain specialist, to a pain clinic, remember, they're treating your symptom called pain. They are not treating your disease. And this family and patient was deceived, if you will, and regardless of whose fault it was, into thinking they did not have to do anything about inflammation or treating their basic disease. They thought this stimulator, this $150,000 implanted device was going to take care of their problems. Well, it took care of their symptoms for a while, but their disease kept growing slowly, and all of a sudden, the inflammation did what inflammation does. Here's what inflammation does. Inflammation that is slow growing, which is the case in the spinal canal, goes into your arachnoid membrane, into your cauda equina nerve, and it slowly grows. Finally, it grows enough that it'll either cause adhesions and scarring, but it may kill the nerve. It may damage the nerve so badly that maybe all it does is make your legs weak and your bladder not work or your bowel incontinent. But it can totally destroy the nerve. It can make it dysfunctional and just give you severe pain. In other words, it causes all of these things. So all of the bad things, all the bad symptoms have as the root cause inflammation. Okay? Now, let me go on one more step and why I'm talking about this tonight. If you have an inflammatory disease of the spinal canal, meaning arachnoiditis, maybe multiple Tarloff cysts, multiple discs, maybe you've got a form of multiple sclerosis, maybe you've got central pain, you're going to have inflammation inside your brain and or your spinal canal. And bank this one, it is not treated with a single drug. It is treated with a multiple drug approach. I want to say one thing about multi-drug approaches these days. In chronic disease treatment, whether you're talking about heart failure, asthma, emphysema, rheumatoid arthritis, diabetes, if you're talking about a chronic disease today, doctors like to use a multi-drug approach. Now, the problem with this, you may not know which drug it is, but these different drugs will approach the problem from a little different biologic standpoint, and the multiple standpoints give you the result. Now, you may not know which drug is the best and what is doing what, but the multi-drug approach is what works. And I'm here to tell you right now, treating inflammation in the lower spinal canal is difficult and it requires multiple drugs, not just one drug, not just one approach, but a multi-drug approach. And let me also say something else that I think needs to be said. The term inflammation is so common that unfortunately, I'm afraid people don't take it seriously. Everybody knows that their last pimple or their last scratch had inflammation, so they kind of relate inflammation to something very simple. But inside the spinal canal, it is a catastrophic disease. Why? Because that inflammation, uncontrolled, is going to wipe out essential nerve roots, essential tissue that you need to function and to also keep, and also it causes severe pain. And so inflammation in the spinal canal is a catastrophic disease that has to be treated with multiple drugs and multi-measures. Now, I'm going to go over some of these right now, but again, I'm going to come back to this. There's not any one magic bullet here. It has to be done. And the second thing that I want to emphasize over and over, pain medications do not treat inflammation. Let me cover something real quick. Ketamine doesn't deal with inflammation. Opioids do not deal with inflammation. Cannabis does not deal with inflammation. Okay, low dose naltrexone, maybe a little bit. Maybe some of these drugs that I've mentioned do a little anti-inflammatory reaction, but not enough to call it therapeutic. So bank that one. When you hear somebody says all you need is your low dose naltrexone, your cannabis, your ketamine, your oxytocin, your opioid, your Percocet, your Vicodin, what have you, you may get a little anti-inflammatory effect from those compounds, but they are fundamentally symptomatic to relieve your pain. They're not going to do the job that has to be done. So bottom line is, you've got to approach this whole issue of arachnoiditis, CRPS, multiple slip discs, a lot of neuropathies in two ways. You've got to have the symptomatic pain relief just to function. But secondly, you've got to tackle the inflammation, the disease itself. You've got to do both. You can't just do one or the other. It's got to be a bilateral, a multi-approach. And so that's the message that we're going to talk about here tonight. Now, I'm going to go over some of the things that we use in adhesive arachnoiditis, or at least that I highly recommend. And hopefully medical practitioners will pick some of this up, and patients and families will pick this up. Now, we're going to start off with what we call the old standards. Okay, there have been two drugs for adhesive arachnoiditis that have stood the test of time, and they're both powerful anti-inflammatory agents. One is the drug Medrol. That's the trade name for methylprednisolone. That is a corticosteroid, and it's the one corticosteroid that gets into the spinal fluid and has receptors in the spinal cord and in the cauda equina, and it is the corticosteroid that will suppress inflammation inside the spinal canal. The other corticosteroid that will do that is dexamethasone, and some people do better on that drug than they do with the Medrol. Now, the second drug that's the old standby is ketorolac, or Toradol is the trade name. Now, today, our recommendations are that these drugs be used on a low dose, intermittent basis. They can have a lot of side effects, but the standard that I try to recommend to people is that they take low dosages of Medrol 1 to 3 days a week. Same way with ketorolac, 1 to 3 days a week. On those bases, you're not going to get the side effects. You're not going to get gastrointestinal bleeding. The corticosteroid, no, is not going to give you osteoporosis. It's not going to shut down your adrenal gland. It's not going to give you cancer. It's not going to ruin your sex life. And it's not going to make you go 3 years. It doesn't do those things on that basis. And so what we've learned is that these two drugs have been the old standbys, and I'm trying some new things right now in our research clinic, but fundamentally, I have been a stalwart in recommending these two drugs for people with adhesive arachnoiditis, and I want you to bank something. In my experience, people who don't use either one or both of these agents don't do very well. After a while, they start deteriorating and the pain gets bad and they start developing more neurologic complications. The bottom line is with adhesive arachnoiditis, our two stalwart drugs has been ketorolac and methylprednisolone. We can certainly help doctors, nurse practitioners, PAs, anybody who's interested. We can give them much more specifics on dosage and on how to use these drugs, but those have been the two drugs that have been our good standbys now for about 15 years. So we've got lots and lots of experience with dozens and dozens of patients. And I do want to pass on the word that if you're not taking one of these two drugs, good luck. That's about my only thing I can tell you is these two things have just been our backbone for adhesive arachnoiditis. Now, let me go on for just a minute. We have identified some alternatives to methylprednisolone and to ketorolac, and they seem to be working fairly well, but we don't have enough experience to say they're better or even equal. But if you are a patient out here and you just can't find a doctor to give you Medrol, then we now recommend that you take something called pregnenolone and DHEA. You take the two together at a dosage. The pregnenolone dosage is about 200 milligrams in the morning and evening. Same way with DHEA. You take these two. If you got doctors who just won't give you ketorolac, a lot of them will give you diclofenac. Okay, that's Voltaren. Now that is the other anti-NSAID, if you will, anti-inflammatory agent that does cross the blood-brain barrier. It does get in the spinal fluid, and it does have some good anti-inflammatory effect on the cauda equina and the arachnoid membrane. And some people are doing fairly well with it with a dosage somewhere from 50 to 100 milligrams a day. So that's one alternative to ketorolac if doctors just won't prescribe the ketorolac. Diclofenac is at least the alternative that I recommend. There are some other good alternatives that are being identified. Two of the peptides have a lot of anti-inflammatory action. One is KPV, and the other is thymosin. Those two peptides are very anti-inflammatory. So in people who can't get ketorolac or can't get Medrol, these two peptides may be an alternative. I don't know how much better they would be or if they're equal, but they do have a lot of anti-inflammatory activity. And so Those are the main medications, if you will. And everybody who has arachnoiditis needs to be taking some of the things that I've just mentioned. Now, the next thing I'd like to cover for a moment is diet. Okay. Now, people get sick and tired of hearing about diets because you can't hardly pick up a newspaper these days or a magazine without somebody telling you what your diet ought to be. But there is such a thing known as an anti-inflammatory diet. And I had the pleasure this week of talking with some Canadian researchers who were able to document that after spinal cord injuries, if they stayed on a high plant diet, in other words, a diet that had a lot of fruits and vegetables in it on a daily basis, and if they did that for about 3 months, their inflammatory cytokines went down. So they had some good objective evidence showing that an anti-inflammatory diet, which is primarily means you're going to eat some fruits and vegetables every day, does seem to help a little bit, and that's highly recommended. The other thing that you need to know about inflammation seems to thrive on sugar. Now, when we're talking about sugar, what we're talking about is this. Sugar is in the blood, known as glucose. Now, that comes from a class of compounds known as carbohydrates. What are carbohydrates? In simple terms, those are the sugars and the starches. Okay. Now, if you're a diabetic, you've got to cut that way down. But if you've got arachnoiditis or intractable pain, what you want to look out for are what I call the sugar surges. Now, what's a sugar surge? All of us know what they are and we all participate in them, but you've got to try to avoid it. That's when you go out there and on one meal or one day, you have some spaghetti, you have a pizza, you have a pie, you have a sandwich. In other words, you take a whole bunch of sugars and starches in on the same day, and that drives up your glucose in a surge. Now, those surges of sugar that pass through your spinal canal or your brain feed inflammation. So you've got to kind of keep your intake of sugars and starches at a low level. You don't want those surges to take place. So that's what I have to say about diet at the moment. Now, let me go on to the next thing that everybody with these conditions needs to know about. And that is of great interest and benefit to everyone is that there are a number of natural herbal compounds that are very good anti-inflammatory agents. And they work very well with the corticosteroids, with the ketorolacs, and with opioids. And these are being taken by most people with these diseases. But like I say, in the last 10 days, I've literally reviewed cases where they're not even taking curcumin. They're not even taking luteolin. They're not even taking any herbal anti-inflammatory. Now, it is my recommendation that if you have MRI proven adhesive arachnoiditis, you need to be taking 2 herbals. 2, not 1, but 2. Why 2? They work on different mechanisms. In other words, we know that inflammation in the spinal canal has something to do with those cells there being inflamed, but you've also got lymphocytes that come floating through in the spinal fluid or in the bloodstream that are also inflammatory. And so we've got different mechanisms we want to try to shut down. These herbal compounds are really quite effective. Some people just literally find that they can't get out of bed without taking their favorite. Now, I'm just going to talk about the ones that people are taking, and we're always looking for new ones. But right now, the ones that seem to be quite popular are astragalus, ashwagandha, luteolin, curcumin, serrapeptase, and I think I forgot 1 or 2 there, but those are at least some that I have mentioned that are worthwhile taking. Okay, and so your herbal anti-inflammatory agents are something that I believe should be taken by everybody. They complement your prescription medications and they give you that multi-drug attack on inflammation. Like I say, you can't overdo your program when it comes to controlling the inflammation. You simply cannot take too many herbs or too many anti-inflammatories because you've got to suppress that inflammation if you're going to have any chance of any long-term recovery, as well as just keeping your pain under control. So now the last thing is a new kid on the block, of course, is the Epstein-Barr virus. we continue to have data show up daily that the virus somehow is involved with almost all cases of multiple sclerosis and adhesive arachnoiditis, and for a variety of ways. And we think the virus does have something to do with fostering inflammation. It doesn't cause the arachnoiditis, trauma usually does, but it causes inflammation to be propagated over time. So the virus, we are still recommending everybody be tested for it and take the medications that suppress the virus or eliminate the virus. And time doesn't permit me to go into it, but we've had a couple of programs on it in the past, and we will in the future. Ivermectin, monolaurin, lysine. There are a number of new things for the virus that are coming out, and we do highly recommend them. And that we, suffice it to say here tonight, we are recommending that people get the Epstein-Barr test. If your doctor doesn't want to order the test for you, call Life Extension. They'll do it without a prescription. Okay? So Life Extension in Florida, just look them up or look up their phone number, call their 800 line, and they will do your Epstein-Barr test without a doctor's prescription. And we highly recommend that. With that, I want to try to move on here tonight, but let me just summarize it. You have two big issues here with these terrible pain conditions. One is you got to have symptomatic pain relief. You can't function without it. You got to have it, but it's symptomatic. It's not going to deal with your disease, and your disease has to be controlled. And if you don't control it, at some point, you're going to wake up one day and all of a sudden find that you're not functioning. You're thrust into bed. You can't work. You can't function. Your bladder, your bowel, your legs, your sex organs quit working, and you just don't have any energy, and your body's sort of been taken over. And that's what happens if you don't treat this disease. Remember, adhesive arachnoiditis in the 1800s was called the devil's disease. They had no treatment. And when I started treating this problem, there was no treatment. And I saw one person after another confined to bed, dying, miserable. And so I've seen the very worst of this disease, and it is a devil's disease, and it is terrible. That's the bad news. The good news is these anti-inflammatory measures work pretty darn well. They may not cure you, but they'll sure keep it under control and let you have a quality of life and keep you from ending up in that terrible, miserable, shortened life that you can expect if you don't tackle the inflammation. So with that message, I want to call forward somebody who's been with us a few times ago. Donna Corley, you're one of the old timers, as they call it. You started off years ago. When I first got started, you were already active. Okay. So we're glad to have you back on the show. You've always got a lot of wisdom to pass on to people. And I've got a few things I want to talk to you about here tonight. First off, for those of you who are not real familiar with her bigger role, she's the director of Arachnoiditis Society for Awareness and Prevention. She's the creator of the Tarloff Cyst Society of America, and she's the administrator of Arachnoiditis Together We Fight. So she's involved with 3 self-care advocacy organizations, and I want to ask you about each one of those in a few minutes. But lately, besides taking care of your own self and your own family, you've also decided to branch out and go into therapeutics. And you've brought to my attention the compound glutathione. What can you tell us or want to tell us about your own history and glutathione? That may be a sleeper out there as far as something to help people.
Well, this is something that I just recently started, and I actually ordered it off of Amazon. Denise Malahan is my go-to when it comes to anything for supplements and stuff. She is just absolutely fantastic at really digging into supplements. My problem is I'm a very poor metabolizer, very slow metabolizer. Anything I take, I have to cut it in half and usually cut it again. That goes for my pain medications, usually muscle relaxers or anything like that, because it takes so long for it to actually get out of my system. Now with the glutathione, I ordered the 500 milligrams, but I ordered it vegan because I am very sensitive to additives and stuff like that. So this is a whole food that I ordered. It's packed full of probably 8 different vegetables along with the glutathione. Um, and it's 500 milligrams. Now, when I first started taking it boosted my energy, but it boosted it so much to the point that I was having problems going to sleep at night. So I had to back off it a little bit. But so far, it's done really well as far as energy, and the burning in my legs, feet have subsided since I've been taking it, and I've only been taking it a week. So that's a huge improvement for me. Now, I still have the problems with my legs going to sleep when I sit down in a certain position for very long. I recently had an MRI probably 3 months ago. They didn't give me any answers as to why that happened. So I've tried different things, and I try to keep up with different things and supplements that works for me, because what works for me may not work for somebody else. But it still goes back to me being on the dexamethasone and the ketorolac for all these years. I have not had any kidney, liver, no side effects from it. But I also take supplements to help counteract any side effects that, you know, have anything to do with your kidneys or liver. So I try to be very conscientious on the medications that I take, the side effects, and how to counteract those side effects. To me, that's very important.
Donna, could you restate that to kind of go along with what I tried to talk about earlier? You've taken the ketorolac and the Medrol for many years, I believe, have you not?
I couldn't take the Medrol because of the side effects. It was just did not work for me. So I started. My doctor put me on dexamethasone and the ketorolac, and I've been on that regimen probably 3 to 4 years. And without that regimen, I would not be able to get out of bed.
Right. So you've been on that, the corticosteroid, one of the two that we recommend, plus the ketorolac for about 4 years, and you're still
Yes.
with it working, right?
Yes,
Functioning
sir.
pretty well. Uh-huh.
I guess you could consider me high function for what I'm able to do. Even though I'm constantly in pain, I can still manage it most days. Now, if I overdo it, a lot of writing, sitting really puts me down, puts me in a lot of pain. But I think that has a lot to do with the Tarlov cyst and the nerve it's compressing on, as far as the sitting, writing, and excess walking. But with the if I do not take my dexamethasone shot once a week, I can't hardly move, and my pain is through the roof.
Mm.
And I'm on a very low dose of that. I'm only on 4 milligrams a week on the dexamethasone.
What is your dosage a week?
4 milligrams of the
4 milligrams,
dexamethasone.
that's all, uh-huh. Yeah,
That's it.
and you've had no side effects from it or adverse effects.
None. But I do the injection. Now I couldn't take it orally.
You take
Um,
the injection
I,
once a week.
I take the injection in my thigh once a week. Now the ketorolac is twice a week at 30 milligrams twice a week, but I don't take it twice a week every single week.
You take it just when you're feeling bad or feel you need it?
I do.
Uh-huh. How old are you now?
53.
53. How long do you think you'll live?
A lot longer, I hope.
I didn't say how long you hope
I
you'll
got,
live. Maybe that's the
I've
same
got
question.
12, I've got 12 grandbabies that keep me busy, so I'm
So
hoping.
you got to stay alive, right?
I do. They keep me busy, so I
Uh-huh.
do. I fight it every day. And it does get hard. I'm not gonna lie, it does get hard. It gets hard knowing you're gonna wake up in pain every single day, and you're going to have to struggle with it every day, but you still push through it. You know, I may not sleep 3 or 4 hours a night, and that's every night, and I've been doing that for years. You know, but and a lot of times pain wakes me up at night when I do go to sleep. So it's just something I think a lot of people don't realize when you live with chronic pain. It's not like something that you can just take and set aside and say, oh, I don't want to deal with this today. Or, you know, this is something that it's pain, but I don't think they realize just how complicated it can get and how it affects not just you physically, but emotionally and mentally, how it truly impacts your life.
Right. Uh, you're here on this show, and hundreds of thousands of people are going to hear what you have to say. So I'd like for you to get on your soapbox, get out your sermon. What's your message to people out there? You're one of the survivors. Okay, you're in your 50s. You're going to live a long time. You've had these terrible diseases. Give us your sermon. Tell us what you think. Give us your message out there to people who are going to hear this and need to hear a success stories like yours.
Well, this actually started when I was 18, my senior year in high school. I had a car wreck and broke my back in 3 places. That's when it initially started with the inflammation. So from age 18 up until now, you know, the adhesive arachnoiditis has just progressed over the years. And then I found out I had Tarlov cyst disease. So I got a large Tarlov cyst in my sacral. And then I was diagnosed with CRPS in my left leg and foot. Um, and I possibly have EDS on top of it. And with all that combined, to me, life is still worth living even through the pain. Don't stop looking for answers. That's that was my motto. Somebody was going to tell me what was wrong with me, that it was not in my head. They couldn't find the reason for my pain, and that was years. I mean, just years and years and years of going to doctors, of being in massive pain, and them telling me, you know, we don't see anything wrong with you. Don't stop pushing for them answers. Don't stop looking. Don't stop looking for ways to help yourself, even when doctors can't or won't, or they won't look outside their little box that they like to put all chronic pain patients in. Keep looking. And I actually was blessed when I was working. I had a patient come in and she wanted me to go see her doctor. And that's how I wound up with my primary care physician, was because of a patient that come in. And that's how I guess that changed my life there with him, because he was willing to listen to me. He was willing to try different things. There are still doctors out there that are willing to do that. It's just finding the right one. And for me, it took years to find that one doctor that was willing to sit down and listen and say, okay, well, you haven't, nobody else has tried this and this and this with you, then let's try it. And he was willing to take your information, Dr. Tennant, that I brought him, and look over it and go by those protocols, run those tests based on your recommendations.
Yeah, well,
So
you've been very fortunate.
I, I
Let me go back to glutathione for just a moment. I've had
okay.
an extremity surgeon who's very knowledgeable about pain, who's been bugging me for quite some time about the benefits of glutathione. Do you know how it works or what it does?
Well, it's packed full of antioxidants, which is what our body needs. Um, and I think that was the biggest thing that really stuck out to me, and something that you had asked me a while back if I would try it. Um, and I finally broke down and ordered it. And so far, I mean, it's done really great for me. And like I said, I've only been on it a week because it took a little while for it to get here. But it's 500 milligrams of the glutathione. And then, like I said, it's vegan and it's packed full of 8 different vegetables.
Right. Well, first off, we're always looking for new herbals, new natural compounds that are going to work. And one of the things that I'm impressed with is you're already on a lot of medications. In other words, for a medication to work in you, it's got to come into the body and hit some specific targets that your current medications aren't hitting. And so I'm impressed that you're with your medical regimen, that you're finding a benefit to anything new. I'm impressed. And one of the things that we haven't explored much with this field are the antioxidants. I mean, the theory is that an inflammation certainly creates a lot of waste products, a lot of oxidants that need to be washed out of the system. Maybe glutathione is really something that everybody should be trying. It's certainly safe. Uh-huh.
Right.
Somebody just asked on the screen, how do you spell it? It's spelled Glutathione. And you can just press it into the internet and you'll have all kind of references come up and sources to buy it. We just need to try it out, do the old therapeutic trial. What have you got to lose? And anyway, I'm
That's
glad you
it.
brought this to our attention because that's what we need. We need people to try new things. But glutathione's been around a while, and like I say, I've got a couple of professional colleagues who's been telling me I've overlooked it. And now you're telling me I've overlooked it. Well, let's not overlook it anymore. Let's try it. I'm going to be asking Dr. Guest and Dr. Ibsen to give their comments on glutathione in a few minutes too. I'd like to shift gears for a second. You're the director or the instigator or ramrod of 3 different organizations. Could you tell us what these organizations are doing now?
Well, they're not organizations. 2 of them are support groups, and the uh, Arachnoiditis Society for Awareness and Prevention is um, basically an activist group. Um, Several of our society went before the FDA. Rhonda was in that. Rhonda's part of the ASAP. We've got Denise Mollahan, we got Terry Anderson, and they went before the FDA back in 2014 with the epidural steroids. Pushed for a ban to be on that, and of course the FDA didn't ban it, but they did push for that and got awareness for that, for the adhesive arachnoiditis on that. And we've done several letters and stuff to Congress and really try to step up and help patients, um, find doctors, anything. I personally have tried to help patients find mobility things to help them when their insurance wouldn't pay for it and stuff like that. I've reached out to other nonprofit organizations to help patients with stuff like that also. So we're all trying to help patients any way we can function better, live better, live a better quality of life. And I think that's what advocacy is about, is sharing what you know and passing that on to somebody else and then passing it on to somebody else. It's about helping
In
anybody you
the,
can when you can.
in your network or organizations,
Mhm.
are people starting to get some help and find doctors? Where do we stand on that, do you think, these days?
I think it's getting a little better. The patients are being diagnosed. The problem is still getting doctors to prescribe the steroids and the ketorolac. For some reason, they're still hardcore on not wanting to prescribe that long term. They'll give you a dose pack maybe once every 2 to 3 months, but you know as well as I do, you're going to have something continual because if not, you get that dose pack, and it, once a month, you still have that inflammation built back up until the next month. So you're still fighting the same vicious cycle when it comes to inflammation. And to me, that's my biggest, that's my hardest hurdle, is something that I'll have to constantly fight for the rest of my life, is the inflammation.
Well, you're sure correct about that. I'd like to call Dr. Scott Gish. Are you here, Handy?
Hi, Dr. Tennant. I'm here.
Good. First off, I'd like to, if you've got some questions for Donna, I'd like to have you ask them that. And then as you're our in-resident pharmacologist, I'd like to get your take on glutathione.
I listened fairly closely. I didn't come up with any real questions, no. But I did do some looking into glutathione, and it does fit right in with the things you've been saying for many years and for many episodes that I've been listening. Glutathione, you want to get the liposomal glutathione, because that's the one that's readily absorbed orally. The dose is going to be usually 500 to 1,000 milligrams a day, broken up into 2 doses, one in the morning, one in the evening. And from the mechanism of action, Donna did go over this. It is an antioxidant, and it protects against autoimmune disorders. I first heard of glutathione from the firefighters here in California. They use that as an injectable form of the drug to clear the toxins and the carcinogens out of their lungs and out of their bodies, and it allows them to live for years. All these toxins and stuff that they breathe in while they're fighting fires, and it's been a lifesaver for many firefighters here in California. I will say the FDA does say it is perfectly safe to take, and we're talking about peptides earlier in the progress. And this is a tripeptide. It's composed of 3 different amino acids and seems to work better when mixed together, as opposed to taking the cysteine, the glutamic acid, and the glycine separately.
So it is a peptide.
It is a peptide. It is a tripeptide.
It's a tripeptide.
Yeah. Very simple. Well, not very similar, but in the same family as the KPV.
And it
is
also
a tripeptide.
And it does sort of suppress some autoimmunity, apparently.
It does suppress autoimmune.
Yes.
But we're talking our language, aren't we?
Yes. And it crosses the blood-brain barrier by a couple of different mechanisms. So if one mechanism is blocked, it can get there by another mechanism.
Yeah.
One of the things that people like to really ask about is the side effects, and they're mostly gastrointestinal. So when I say, it's 500 to 1,000 milligrams a day, don't jump out and start right at the 1,000 milligrams twice a day. It's going to really upset your stomach, and it's mostly going to be bloating, nausea, and then diarrhea at higher doses. So start, as we always say in medicine, start low, go slow. Other side effect that was listed was headache, but every drug in the PDR is going to list headache as a side effect. So I really don't put much count into that one. And then some flushing. There is a possibility that you can get some flushing with this drug. Something like niacin causes flushing as well. Again, not that big of a deal. And you can titrate the dose so you can really avoid most of those. And there is a precursor to glutathione, and it's been spoken about a number of times on this channel, and it's called NAC, or N-acetylcysteine. N-acetylcysteine turns into glutathione. But if you have trouble converting, then don't do that. Just go with a straight glutathione. And that's pretty much what I have on glutathione.
Let's talk about a therapeutic trial for those people that would like to try it. Give me your thoughts on trial. And our definition of a therapeutic trial, that is, what have you got to lose? Now, what would be your recommendation? Try it for a week, 3 weeks. What's your recommendation on a therapeutic trial?
6 weeks is my usual recommendation on trying anything new, especially with the glutathione, where you're going to start low and work your way up. You're going to spend 2 weeks getting up to the higher dosage, and then you want to give yourself at least a month to see if it's going to work for you. Especially something as slow going as bringing down inflammation and suppressing inflammatory processes once it gets into the blood-brain barrier.
Next question. It sounds like we've been too slow at the draw on this. How come we've been negligent in bringing this out before? Are we going to depend on Donna Corley to do everything for us?
We as a group, we're not depending on one person to do anything for us. It's a community event. It takes a
That's right.
village.
That's right.
You're in good hands with Donna.
That's very, all right, Mark, since we've got you up. Okay. Questions for Donna? Your take on glutathione. Give us your take on all of this.
Well, I just did a quick research this afternoon and I couldn't find anything close to what Dr. Guest just recommended. So I'd listen to him on glutathione. I think the side effects of many nutritional supplements is to realize that you might have expensive urine. If you take something and it doesn't harm you and you pee it out, then it's worth a try. And so it might work for somebody else. I just appreciate the fact that we have lots of options now. Those of us who, you asked me earlier about people, pain clinics that treat patients with a spinal cord stimulator. If you came to see me in the ER and you were short of breath and all I did was add oxygen, I wouldn't be serving you very well, would I? I'm looking for asthma, pneumonia, pulmonary emboli, congestive heart failure. There's a lot of things that cause shortness of breath. So every symptom deserves, and every patient who has a symptom deserves a conversation about what does it mean and what diagnosis can I develop? And if I get a diagnosis, does it include a therapy? So this is absolutely true about how the pain docs, particularly the interventional ones, are really just interested in they're not that interested in relieving your pain, frankly. They're interested in padding their bank account with procedures. So, depending on how many kids they have in college, that's the amount of procedures they'll offer you. As far as your own illness, you are the expert in your disease, patients. The doctor is not, because he or she does not have the illness. You have the illness. You have the motivation to develop the expertise to treat the illness. And if you have a therapy that you need and your doctor won't provide it, find someone else.
Very well put. Mark, we have some time left. Earlier today, you told me that in your loving world-class project to take care of pain orphans, you had a few miracles to tell us. I'd like to have your take on that. Anytime I hear the word miracle from Mark Ibsen, I want to hear about it. Okay.
Okay. Well, I've got a great announcement. It starts off kind of dramatic and bad, and it has a better result. So you all know I've been treating Brandy Stokes in Maine for almost over 2 years now, and that she, back in July, hit a brick wall when the Rite Aid store in New Hampshire that she was going to, no one in Maine would fill her prescriptions. She goes to New Hampshire, and we treated her there for about a year, and then that store closed, and no one else in New Hampshire would fill her prescriptions. Since July, she's had nothing from me. She had to go back to her nurse practitioners in Bangor, and they resumed her forced taper at the level she was at before she and I started working together. So she was in agony, and I was afraid she was going to die. And her blood pressure is 240 over 180. She's now bedridden. Her legs don't work. She can't even use her crutches. She's in her wheelchair and either in bed, in the recliner, or in her wheelchair. And I've been beside myself over it because there's nothing else I could do for her. I was re-listening to the Cato Institute presentation that we did where Brandy talked about it, and it's on the internet, from Jeffrey Singer. He talks about how pain refugees are the unintended consequence of restricting pain access. So I listened to that the other day and I thought I should call Brandy. So I called her to check on her, not to stalk her, but to see if she's still alive. And she answered the phone in the most pleasant voice. And she said, "Guess where I am?" I said, "I have no idea." She said, "I'm at Massachusetts General Hospital." So what happened is she wanted to die and her sons and family didn't want to let her die. And she was getting worse and worse. And she's basically back where she was when I started treating her. Her sons bundled her up, dragged her in the car all the way to Mass General and showed up there. And she's been hospitalized for several days. They've worked her up. They've documented that she's palliative care. There's nothing else they can do for her. And she's getting her pain treated. That's why she sounded so much better to me. And she is hopeful that another session in Boston where all the smart doctors are, ask them, she'll be able to take that information back to Maine or New Hampshire and find a pharmacy that'll fill her prescriptions. She has a week worth now. She promises to call me next week to see where she's going to get her prescriptions filled. And it was a bold move, kind of a last gasp, if you will. And for this week, she's treated. Now that's the same thing for all of us, you're treated for a week, you don't know if you're going to continue. But what I want to acknowledge is that the determination of her children to get her treated outside of the wasteland of Maine where pain management is not happening. So I consider that a miracle that A, she's still alive, B, she got admitted, and C, they documented that there's nothing else to be done for her other than treat her pain. So I consider that a win, and it reinforces to me the need to not give up. All of us need to keep the conversation alive with our families, with ourselves, with our doctors, and hope to God that at some point the medical system will come to its senses and treat pain like we treat everything else, effectively, compassionately, and without fear or favor. That's all.
Mark, you used the word a while ago, which I think I wanted you to dwell on a little bit. And this whole thing with these pain refugees, these tragic cases that need high dosages, unusual therapies, or unintended consequences. I guarantee you, if you went and asked any politician, any medical board, any insurance company, they're going to tell you things are just fine. These people don't exist. They're totally, no one believes we have these refugees. How do we break through this? I mean, I'm serious. These people legitimately don't believe we have people who aren't getting care.
Okay, I'll tell you how. I believe that there's so much lying and disinformation and misinformation in this setting that the only way to get this resolved is having people under oath. Now, there's two ways to do that. One is congressional hearings, and we've been trying for 2 years to get those. The other is a court case. So I've been treating patients since November of 2022, and I have now 80 pain refugees that I'm treating, and I now have a federal case pending. And I received a subpoena, and that's pending, but I think there's going to be a trial. And I think we have to face the facts that they're going to put doctors on trial, and we got to find a formula for doctors to win their cases. And that includes, legal representation, raising the funds to do it, and speaking truth to power, not desperately, not arrogantly, which is how I usually do it, but factually and listening for what it is that those guys want to know, and then maybe provide it to them. I'm taking a big risk. I knew I was taking a risk when I got back into treating opiates, and I hope that my case will get some people under oath that we can actually document, have a transcript for, publicize it, and then let it spread from there and get a bandwagon going. And once we get a bandwagon moving, the lawyers will jump in, and then we'll start winning some cases for malpractice, for abandonment, all those other kind of things. The other thing that's really hopeful to me, that's somewhat miraculous, is pharmacist Steve did an AI perplexity investigation of what's going on in my state, and he sent it to me, and I'll share it with you all. Essentially, it said the Board of Medicine and pharmacies are all breaking the law by undertreating pain, by discharging patients, by harassing doctors. I've had 23 complaints from the Board of Medicine, started by the Board of Medicine, and I've won them all. And so what did they do? They referred me to the feds, and that's why the feds are investigating me. That kind of shit has got to stop. And we're going to have to encounter the Federation of State Medical Boards over all 50 states. They've all drank the Kool-Aid. Their abandonment of science is appalling. We present genetic pleomorphism to pharmacists, and they say, well, we don't believe in that. And it's like, well, do you believe in eclipses? Because if you don't believe in any science, then you should be dancing in the dark with fireflies or something, or some other kind of superstitious thing. And it's basically superstition. So we got to bring science back to the practice of medicine, and I'm intending to do that. You may notice more animation in my voice. I went through a really dark period the last several weeks, and I'm done with that shit.
Yeah, okay.
That's all.
Your words speak great wisdom, and we need to follow your lead. Thank you very much.
Thank
And
you.
also, I appreciate your loving, caring attitude toward helping these cast outs, because they just, again, I know I've sent you a few people, and I'm so grateful you're there and willing to take the risk, and it's up to us to back you.
Thank
Okay,
you.
thanks so much. We're about to close out here for tonight. I want to thank Donna Corley for her words of wisdom, and also maybe bringing forth a peptide that we all need to take a new look at. It sounds like we might have something that might be a real help. And for those of you who are listening, try that new peptide glutathione out. Let's see if it works. It certainly worked for Donna. And again, thanks, Scott Guest, for being here and bringing us the great pharmacology that you always do. It's been a great show. We'll all see you next week. Have a good one. Bye-bye.
Bye.
You're not alone.
Thank you, everyone. You're not alone. Good
You're
night.
not alone. We are not alone.
That's right.
We are not alone.
We are not
Amen.
alone.
That's
God
right.
bless
bless
you,
us,
Donna.
everyone.
God bless us, everyone.
God
Love,
bless.
love you guys.
Love you.
Thank you,
See you
Tisa.
Love
guys.
you. Love you.
Bye, everybody.
Beautiful.
Stay
Bye-bye.
alive.
Have
No
a
matter
great
what
weekend.
occurs,
Thank you,
stay alive.
everybody. Yes,
Always hope.
always. Oh, hope never dies. Good night.
Love you guys.
God bless you. Love you.
Love you.
Oh.
See you next week.
Good to hear laughter and joy. Yes, joy
Aw.
sustains you.
Thank you, everybody.
Love you.
Love y'all.
Happy trails to you until we
We
meet
meet
again.
again.
Happy trails to you. Keep
I love
smiling until then.
You
Night,
go,
night.
Dr. Ibsen. God bless
Great.
you.
God bless you, Dr. Ibsen. You
Yeah.
spirit.
Yeah, are we leaving? I just don't want to push the button.
This is my first time doing this. I didn't know we could do this. So
Oh,
yeah.
Coming
with
back,
us
baby.
every week. Yeah, come
So
be
I'll
with us
probably,
every
I'll
week.
probably see y'all back
Beautiful.
here.
Good.
We are the island
All right.
of misfit toys. We'll be fine.
We will. We will. We're
Night, y'all.
stronger
Nice
together.
Bye.
We're stronger together.
1,
Yes.
2.
I know, right? One at the
Nobody
same
wants
time.
to leave.
Good night, y'all.
Good
Good
night.
night.
Good
Good
night,
night.
everybody.
Eddie.